Hello and welcome to our latest Pediatric MS Navigating Your Journey program. My name is Krista Harding, and I'm a senior manager in the community engagement team at the National MS Society. As we get started today, we want to remind you that the Society's mission is to cure MS while empowering people affected by MS to live their best lives. We also want everyone to feel comfortable coming to the National MS Society for support. For that reason, we share our inclusion, diversity, equity, and accessibility statement at the top of our program. We amplify the voices of all people affected by MS and celebrate our differences in the drive to end MS. We affirm the space for everyone to express their perspectives, fueling our vision with innovative ideas and insights. We commit to advancing inclusion, diversity, equity, and accessibility within our workforce and across the MS movement. So, for those of you who are joining us for the first time, we start each of these programs with a brief overview of pediatric MS. Before you or your child were diagnosed with MS, you may not have known anyone with MS, or you may not have even heard of it before. We learned from a study published in 2019 that nearly 1 million people live with MS in the US, and there are 2.8 million people worldwide living with it. It's estimated that fewer than 5,000 children and teens live with MS in the US, and fewer than 10,000 teens live with MS worldwide. So, what exactly is MS? MS is a disease of the nervous system, which includes your brain, the spinal cord on your back, and your optic nerves, which connect your eyes to your brain. In MS, the body accidentally attacks normal cells called myelin, and when that's damaged, it's difficult for nerve cells to send and receive information to and from the brain. One way to imagine this is to think about when a phone charging cord gets damaged. If the outside coating isn't doing its job, the wires underneath might not work as they should, and charging could become slower. So, like the charging cord, damage to myelin may slow down the messages your brain is sending to the rest of your body. These attacks produce something called lesions, which can cause symptoms in MS. We don't know yet what causes MS, but researchers are working hard to figure it out. We do know that women are 3 times more likely to have MS than men, and that MS is more common the further away you get from the equator. We know that you don't get MS directly from your parents, but that some of your DNA, called genes, may make you more likely to get MS. In fact, if someone's mother or father has MS, their chance of getting it themselves is just 1.5%. And if their sibling has it, the chance of getting it themselves is 2.7%. Having low vitamin D levels, being overweight as a kid, smoking or living with someone who smokes, or having been sick with mono could also make you more likely to have MS. However, it's important to know that there is nothing you or your parents did that caused you to get MS. Scientists believe that getting MS is caused by a combination of factors, and many of them are completely out of your control. There are 4 types of MS, but for young people, relapsing remitting MS is the most common. People with relapsing remitting MS often feel fine, but then have periods when their symptoms last for more than a day and feel much stronger. Those periods are called relapses, but some people call them exacerbations, attacks, or flare-ups. All these words mean the same thing. It makes your MS feel worse. Even though relapses last longer than a day, you will feel better once they end. Most young people recover well from relapses, and relapses don't necessarily cause permanent change. There's nothing you did wrong that made you have a relapse, and some medicines can help you manage them. MS can make your body feel strange, and everyone's experience with MS is different. Sometimes your vision might become blurry, your hands might tingle, or your foot feels numb for a while. Some of you might feel really tired every day, or like you can't focus at school, and others might feel sad or worry or be in a bad mood a lot. Maybe you feel a couple of these together, and maybe there's symptoms that come and go. All of this is normal with MS. There are things you can do to help your body feel good, like eating nutritious foods and being active. And even though we don't yet have a cure for MS, there are medicines you can take to help, both for your body and for your mind. To treat your MS, your doctor might prescribe a disease-modifying therapy. The goal of these medications is to prevent MS from getting worse by preventing new damage, those lesions we talked about earlier, from being formed. The medicine might not make someone feel better, and because of that, they might not want to take it sometimes. But it's constantly working inside their body to help stop them from having new changes or relapses in the future. They may not even notice that it's doing its job, but it is. MS medicine will work the best when someone starts taking it as soon as they find out they have MS and continues to take it regularly as prescribed by their doctor. Because everyone's MS is different, medicines work differently for each person too. So your doctors might want to try out a few different kinds right away or in the future. No matter which one you choose, the best medicine for you is one that you, your parents, and your doctors decide is the right fit to help you feel as good as possible. If you are a young person living with MS, I want you to know that the way you feel about your MS treatment matters. Your doctors want to know how you're feeling and to hear about your experience with your MS medicines. Your opinions matter, and I would encourage you to be an active part of your own care team. And
Thank,
now I'm pleased to introduce today's speaker. Dr. W Abrams is a pediatric neurologist and co-director of the Pediatric MS and Neuroimmunology program at Cleveland Clinic with expertise in pediatric onset MS and other neuroinflammatory diseases of childhood. He grew up in Providence, Rhode Island, and currently lives in Cleveland, where he cares for patients at the Cleveland Clinic. He's been working closely with the National MS Society since his pediatric MS fellowship training at UCSF and continues to be an active part of the organization. Welcome, Dr. Abrams.
thank you so much. It's a pleasure to be here. So I'm talking today about transition of care in pediatric MS. So with pediatric MS, treatment advances have helped enormously in slowing MS progression. But there also is always the question about how much effort it takes to maintain that stability. And those are things that often happen more behind the scenes, and are not necessarily a central focus of each visit. But I think it's important to focus on those kinds of things during this presentation. Being diagnosed with MS in childhood can make it feel like the child will never be able to live a full and independent and successful life, but that is absolutely not true, and we're here to help every step of the way. Managing pediatric MS can be challenging even for parents and caregivers, and then to expect a child to take over their care in the not too distant future might feel next to impossible. But it is essential as it can help set them up for lifelong success. MS management involves huge investments in time, energy, and cost. That involves appointments, treatments, MRIs, hospitalizations, rehabilitation, both in terms of the travel it takes to get there, and sometimes it requires going to facilities that are further away. In terms of costs, those can be both travel expenses as well as payments for visits, as well as procedures. And in addition to all of that time and energy and financial burden, there also is this constant fear of having a relapse, getting an infection, because of being on an immunomodulatory, as well as all the possible missing of school and activities that the child has to face. And all of this is happening oftentimes when the child is still trying to come to terms with a diagnosis of MS, which is, of course, a rare but lifelong disease, at least rare with respect to it occurring in children. And that involves neurological deficits, fatigue, as well as treatment side effects, just to name a few things. The transition from pediatric to adult-focused care often comes at a time across the board when young adults are facing other major life transitions. This usually happens around late adolescence and then the transition into early adulthood. And there's so many other major life transitions that are happening around that same time, including college, going off to college either near home or far away from home, as well as employment opportunities, other types of, trade school or other scholastic opportunities, as well as things like marriage and family planning, often are happening, around that time or at least in the near future. And so you can imagine, how overwhelming, it can be to be juggling all of these things, and also need to focus on, trying to transition from a pediatric to adult focused clinical setting. So even for healthy children, the healthcare system, struggles with transitioning children to adult focused care. These are really hot topics among, the American Academy of Pediatrics and other pediatric focused societies, and expert consensus specialists where these are really challenges for the healthcare system as a whole. Um, and you can imagine also how much more challenging then this can become for children who are living with a chronic illness. Um, if there's already barriers in place even for, otherwise healthy children, then you can imagine how difficult it would be. So research on transition in other pediatric chronic diseases, such as asthma, epilepsy, diabetes, arthritis, heart disease, cancer. Um, these are things that have elucidated pretty major barriers to transition, and those are things that a lot of different societies and foundations supporting these diseases, tries to address. And the major barriers that have been identified include access to care, um, potential lapses or inadequate insurance coverage, um, distance, to medical facilities, both for treatments as well as for follow-up visits. Many times patients and families, will live pretty far away from an MRI facility. They may live closer to an accessible infusion center. But there's so many different facets of care for these patients. Um, other barriers that have been identified include the costs, as we talked about from a financial standpoint, as well as provider availability. There sometimes are pediatric specialists that may not, have a as robust a network of, other adult focused providers, that maybe feel as comfortable managing, the pediatric onset of that disease. Um, there also have been barriers identified in terms of provider to provider handoff and how the transition actually occurs with respect to, the transition, the person who's transitioning being able to then, inform adequately the person they're transitioning to in order to ensure that all of the medical information, tests, as well as treatment continuation, don't fall through the cracks. And then another barrier is also, there's a lot of work being done on transition readiness, and how do we assess when a pediatric patient with a certain type of chronic disease like MS, for example, how do we know when that individual, that family, is ready for transition? When there's so many different, pieces that have to go into making a decision like that. Because of course, we never want to transition patients who aren't ready and that, are then once they transition are going to be at risk of getting, inadequate care or suboptimal care. Um, and one of the other challenges with transition is that disadvantaged populations have been shown to be particularly at risk, both in terms of racial and ethnic minorities, as well as socioeconomically disadvantaged groups. So this slide highlights the importance of transition, really kind of for early transition with at least with respect to MS. Early preparation and effective transition can lay the foundation for lifelong consistent follow-up in a young patient. So this can involve continuation of appropriate specialty care, so making sure that either the pediatric MS specialist who's caring for the child continues that care, or hands off to another pediatric MS specialist, depending on, for example, if the child decides, or plans to move away to college or for a job, or potentially transitioning over to an adult MS colleague who is comfortable managing pediatric onset MS. Other aspects that really can help with the transition process, it includes things like disease activity surveillance and making sure that that there's a seamless monitoring of disease activity, and making sure that the treatment that the patient is on is the right one for them and is effective, and also has is not having too many side effects that can be burdensome, and that plays into also the importance of ongoing treatment adherence, and not making sure that treatment doesn't lapse, or that side effects don't become too problematic. And this also includes, helps to focus on healthy lifestyle habits from a very early stage, meeting with your MS care team, and making sure that vitamin D levels are optimized, which is so important for MS, as well as so many other things in terms of healthy lifestyle that really have been shown both in pediatric and adult MS to be very important for better outcomes, and helping with prevention of progression. And that includes things like exercise, healthy diet, as well as mental wellness. And some of the things that have been shown in some of these diseases, chronic diseases of childhood, have demonstrated that really this can lead to better health-related outcomes as well as quality of life. And some of the specific things that have been looked at include better adherence to care, better markers of both disease activity as well as longer-term disability, quality of life, and self-report and family and patient and parent report of how happy they are, satisfied, fulfilled they feel in their lives, as well as self-care skills, independence, and being able to take care of themselves long term, which can of course set them up for success, as well as things like satisfaction with their care, better healthcare utilization, and a smoother transition process. So when it comes to MS, there have been some studies that have looked at this particular topic in children, and it does appear that similar barriers are experienced as what we've seen in other chronic diseases of childhood. And some of those, again, to reiterate, include access to appropriate care, overcoming social and emotional barriers, as well as succeeding academically and professionally. one of the challenges though is that, there hasn't been a whole lot of research into transition for pediatric MS. And so some of the work that we're doing is, and one of the big focuses of this talk is how do we make sure that we are effectively transitioning pediatric MS patients to adult care, so that they can make sure that they are able to have better outcomes, as well as prevent lapses in treatment, and really important things, and really on a longitudinal basis, for life. So one of the big challenges with transition is how can we ensure that children living with MS are not overwhelmed by the transition process, but they're still able to develop these skills and tools necessary to lead independent, full, and successful lives. So one of the big aims that myself and colleagues have been working on is, the first step was really to send surveys out to look at current transition practices at major pediatric MS centers in the United States, and start to get a sense of how different sites and providers are transitioning patients, and how we can potentially improve upon those practices. So the typical transition age that we found based off of the surveys across 10 major pediatric MS centers in the United States showed that really the youngest age at which centers reported transitioning patients was 20 years of age. So you can see how the age of 18, which is often seen as, at least in the US healthcare system, the sort of time when a child becomes an adult, at least from a sort of a lot of times from an insurance standpoint, from a medical decision-making standpoint. That's just the reality of the US healthcare system. But you can see how, the majority of sites, you know, tend to transition patients, after that point. And part of the reason for that is probably because, they want to really make sure that the patient, is continuing to get the best care that they can possibly get, and not transition, too early. I think one of the interesting things on that topic is that, a lot of the focus of other of like the American Academy of Pediatrics and other other specialty committees is really to try and transition patients as early as possible, but at the same time making sure that they're comfortable doing that. And so I think to some degree it can be difficult to kind of figure out for an individual patient and family, when is the right time to transition. And that's one of the things that we really are trying to clear up. Almost half of the sites reported transitioning to themselves in the adult-based setting. And then the remainder reported that they would transition patients over to their adult MS colleagues, usually within their same institution. So most of the centers in the surveys did cite significant barriers to transition. And some of the highlights were ones that really were not, all that surprising based off of, what I discussed with respect to other childhood chronic disease. But some of the major ones included that were cited more often included concerns and barriers regarding insurance coverage and potential lapses in insurance coverage, and families being concerned about whether their child will continue to be covered, either as they turn 18 or beyond, depending on the age that they're transitioned. Um, other big things were the cost involved, for patients and families in terms of transition potentially requiring traveling longer distances, whether it's to, a new clinical site or whether it's to, a different infusion center and those kinds of things. And that kind of plays into also the travel time that's required. There was also reports about concerns about potential access problems to infusion facilities. For example, there are some infusion facilities that are mainly focused on treating, pediatric patients. And so as the pediatric patient, is gets older, one big question is, do they continue to receive their MS infusions and treatments at the pediatric center, or do they need to be transitioned not only from a clinical setting, but also from a treatment setting to, an adult based infusion center. And then one of the other things that centers also brought up was a lack of psychosocial support and really kind of helping to guide and support families as they face these questions about transition. And so, I think from this, it's clear that that we can do more, to help families and patients, figure out, what sorts of resource and things are available to help them through this process. So some of the critical areas that were reported by the various sites that were important areas to highlight as we start to work on how we can optimize transition and make sure it's effective and that patients and families are adequately prepared. Some of these areas include, as we discussed, a formal assessment of transition readiness and how can we standardize that, but also make sure that we are individualizing and personalizing it to each particular child, because of course there's so many nuances to transition readiness, as well as concerns about lapses in treatment. If a patient is transitioned to a different clinic setting or a different provider, how do we make sure that that the treatments don't lapse, especially infusion-based treatments, but also even oral treatments as well, in terms of handing off who becomes the prescriber, and how do we make sure that it's being sent to the correct pharmacy and all of those kinds of things. And then another critical area to address was how do we ensure ongoing safety monitoring, in addition to concerns, I think, about lapses in treatment. There can be situations where, for example, a patient continues to get their medication, but because they've been transitioned elsewhere, or to a different clinical setting, they may have more difficulty or not even know, where to go to get their labs drawn and things like that, which are, so vital for being on, of course, these disease modifying therapies that, where we really need to continue to monitor for things like infections and other potential side effects. And I think one of the most important aspects of this project on transition was really that all of the sites, expressed strong interest and felt that it would be really beneficial to have a formal transition guide in order to help really inform best practices when it comes to transition of care. And just to finish up in terms of some of the research that's going on with respect to transition, I think the future directions for these types of projects are going to need to focus on surveying, of course, patients, families, caregivers themselves, right? And we've started to kind of look at how the clinics and the investigators and the providers are transitioning and what barriers they face. But the most important thing, of course, is how do we um, get input and guidance from patients and families and caregivers themselves, um, and what barriers do they face, and are those barriers the same or are they different from the barriers and the challenges that the providers or the clinical settings are reporting. And then, of course, definitely needing to develop and validate a transition readiness tool, that can be applied, and done, efficiently but accurately in a clinic visit setting. Um, and then the ultimate goal, will be to create and then be able to really test, a best practices implementation guide, and and gauge whether we're able to um, further optimize follow-up care longitudinally for pediatric onset MS patients, as well as quality of life and preventing lapses in treatment, as well as kind of just overall disease-related activity, and that's really the overall goal here. So shifting a little bit towards talking about the transition team. So as a pediatric MS patient and family, I think the emphasis really needs to be that your pediatric MS care team is also your transition team. So, learning, and the most important thing really is learning how to advocate for yourself. Certainly the care team, has things in place and approaches that they try and implement in order to, discuss transition early on and prepare, patients and families for the transition process. But I can't stress enough how important it is, for you really are your best advocate. And that should really be clear from the moment you step into your pediatric MS provider's office for the first time. Um, and, you know, really, yourself, your child's, far better than the care team ever can, right? We're often seeing, patients and families in a limited amount of time, right, periodically, and that can be very challenging. And really, the more you and families are able to speak up and tell us what's going on, the more we can then be that guide and support network for you. Um, so even though we might have all these tools to diagnose, monitor, prevent MS progression, as we've talked about thus far, there are so many different factors and complexities and nuances to MS management and care, that really kind of the 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 more the patient and the family are able to inform us of what's going on in their day-to-day lives, the more we're able to then come up with a plan for how we can help guide things moving forward. Um, and so that kind of emphasizes that we want to be so much more than sort of just the diagnostician or the treatment provider, right? We want to really be your guiding light and your support network throughout this process, and you really can help us to achieve that the most. So practically speaking, what can you do? Um, So as I mentioned, talking to your care team about what challenges you might face in everyday life early on can really help to identify future barriers to transition. I find that a lot of times, um, the barriers that we identify for individual patients and families when it comes to transition oftentimes stem from really just these sort of what seems like pretty routine kind of conversations, just checking in on how you're doing, how is school going, social life, activity, right? Are there any barriers in terms of, physical activity and fatigue, as well as, potential ongoing neurological deficits. And you'd be surprised at how many of those conversations for me, I think really kind of tease out sort of what and allow me to anticipate what are the potential barriers that we may face for that individual moving forward as it relates potentially to transition. Um, in addition, just talking about those challenges that the family, the child is facing on a day-to-day basis can really help to foster growth, development, as well as mature attitudes and practices. And all of that is with that big goal in mind of carving out this path and helping to support this goal that the child can become independent, can live a healthy full life. um, and that's the aspect of the care that we've had so much advances and done so much work on the treatments, right, and being able to prevent and slow progression. But we still need to really kind of emphasize at every single visit. And again, you can be your best advocates for this on continuing, to practice healthy living, um, and working with your care team and your provider, to help guide you along the way so that you can really reach, your absolute full potential. So the first step in transition, and some of these things will differ, a bit in terms of the specific provider, the practice, but, I think it's helpful to kind of have at least a general sort of framework of how I and many, many colleagues sort of approach the transition question. And so really the first step is laying that foundation for transition. And what I mean by this is really kind of setting very early on, what are the goals and expectations, both of the family as well as, parents, caregivers, and as well as the patient, and I have some families, right, who bring, three or four, family members to the first visit, and and that continues, right, at every visit. And I have others where it's one, it's a mom or a dad, and the child, right? And I think it's so important to really recognize and acknowledge that, because I think everybody in the room, but even people, who may not be in the room, because they have other, they can't make the appointment because of, their job or whatever it is. I think it's so important to kind of figure out who are the key stakeholders within the family unit and beyond. And because really each of those individuals becomes such um, a support person, and a focal point for helping the child to along the way, both in terms of coping with this new diagnosis and going through the treatments and all of these types of things. And really, again, on that road towards, independent, healthy living, where they get to a point where they can really manage, their MS care on their own, but with those support networks still in place. Um, and so in terms of setting those goals and expectations early on, once you and your care team have confirmed the diagnosis and have decided on a treatment plan, and really once, the disease, right, and the activity has been stabilized, I think that is a great point, a great time to start discussing the goals and expectations, and focusing on what are the goals of the caregiver, what are the goals of the child. It's okay for those things to differ, right? And they will differ, especially early on. Um, but the key here is just starting the conversation, right? And that's the first step. So if your provider doesn't bring it up, and doesn't bring up, let's say in the first few visits, sort of what is the picture going to look like when it comes to transition of care, and the kind of the what that process looks like may look very different for a newly diagnosed 13-year-old, right, versus a newly diagnosed 17-year-old. But the key here is, if it's not brought up, you really should feel confident that you have every right to bring it up. And it's really your prerogative to bring this up, because ultimately all it will do is to help the provider and the team um, address any concerns that you have, and then identify those barriers early on, so that we can make sure that the transition is as smooth as possible. Um, and all of this, again, through all of these conversations, even though the focus here is really on transition, these are things that really help to just kind of open up the conversation, and really kind of shift things from, you know, treatment and side effects and, things that are, of course, very, very important for us to keep up to date on, but more kind of those behind the scenes nuances of the everyday life, which really helps to then foster this building of rapport and trust among all the different individuals involved in the child's care. And that's the child, the caregiver, as well as the entire care team. So an example that I wanted to give, so let's give an example of a child whose name is Henry. He's 13 years old, and he's diagnosed with MS, and that is really kind of the conversation at the first visit with his pediatric MS care team. He probably, right, was in the hospital with an acute, neurological event, weakness, and, had an MRI, and then comes to his, pediatric MS care team. And, they look through everything and then do an exam and, talk through the history and diagnose Henry with multiple sclerosis. And then at the second visit, they focus on treatment options, and the decision is made to start, Henry on rituximab. Um, and, over the next few weeks, he schedules, his first infusions, and everything goes really well. There's no side effects. And then on follow-up MRI, the disease has stabilized, and seems like things, from a disease activity standpoint are going well. Um, and so at the third visit, Henry and his mom, have taken it upon themselves to be advocates, right? And they bring up to their care team that they'd like to discuss their goals and expectations. And this is a fantastic opportunity also to just ask your care team, what are the expectations moving forward? Is there a certain age that the provider or the care team, tends to transition patients, and how does that transition work? Where do they transition to? Will the provider that you're seeing be that same provider, for Henry's whole entire life, or, and how do those things work? And so one of the things, when Henry and his mom, are talking about sort of goals and expectations, and oftentimes, with a 13-year-old, right, the mom will often initiate the conversation. And I think, it's important for the provider and the care team to, both talk with mom, of course, about what her goals and expectations are, but then to also, involve Henry, who's at 13, can certainly be, most likely part of the conversation. Um, and, wanting, and Henry from that discussion expresses that he really wants to learn more about how MS will affect his body and really his ability to play soccer, which he is loving right now, and he's on the soccer team, and he's worried that, all of these things that he's been experiencing, weakness, fatigue, will really limit his ability to play soccer like he used to be able to, right? And very differently, Henry's mom is saying that she worries about whether Henry will be able to keep up his grades, with all of these doctor appointments and treatments and potential side effects, because she has always really wanted, Henry to go to college. Okay. And so you can see that although their early goals differ enormously, the care team is starting to learn that, at least at the beginning stages, it will be really helpful to focus conversations with Henry on further education about MS and how valuable it is to have in place rehab-based therapies and keep up his activity and healthy lifestyle, so that he can, continue to play and soccer and do what he loves to do. And then at the same time, and often having these conversations jointly with everyone involved and listening is so important. And also addressing, mom's desire to, to have Henry be able to grow up and become really an independent young man that can go to college and get a job and be successful, right? And the way, one initial easy kind of a way to start that process is, okay, Henry, why don't we talk with mom here about how can we look at, the schedule that mom probably has, on her iPhone, on her calendar, and, can we look at it together, and maybe see like, okay, which days, in terms of school and activity, extracurriculars and soccer, can we have Henry start to really, plan for visits and treatments and MRIs and all of these things, and really kind of be involved with scheduling, around his busy schedule. And that is such an important first step in getting, Henry involved, right? And sort of taking ownership of this new diagnosis, right? And it seems, so trivial, but it's this larger theme, of having Henry, having mom be involved, and be really taking care and managing everything up to this point, to shifting that focus over to Henry and giving him the confidence and the tools to start to really, be able to manage aspects of his new diagnosis himself, right? And so over time, he can really begin to learn how to integrate MS management into his daily life. So the second step, and again, this isn't necessarily kind of like, okay, at the first, at the third visit, you do the foundational stuff, right? And then at the fourth visit, you do the step two and the integration. Like, this is a very fluid and dynamic process, but the key is just kind of reiterating and making sure that it becomes a topic of conversation, even if it's, 5-10 minutes of the visit, and the rest of the visit is dedicated to, you know, disease activity and monitoring side effects and, treatment and scheduling and all those kinds of things that are so important with MS care. And so that integration piece is really starting to get in the habit of making this conversation a part of every visit. And so just setting aside, and again, if your care team, your provider, you know, forgets, or if they, have a whole lot of other things that they were planning to discuss with respect to labs and, treatments and side effects and things like that, just, you know, it's your prerogative, to at some point either interrupt them nicely, or just make sure that, that you advocate for yourself in carving out this time, 5 to 10 minutes at the end, at the beginning, whenever works, to check in on whether those initial goals, expectations that were discussed previously are being met, and what new ones may have come up in the meantime. Because the key, again, with this fluid dynamic process is that things will evolve, but they will build on each other. And each building block gives Henry that confidence to start to manage his own care, right? And so the other piece is that, these building blocks also at the same time kind of allowed your provider and your care team to really be able to address these ongoing everyday concerns and potential challenges, which again can sort of later on very much influence potential barriers to transition, so that they can really help to provide comprehensive, relevant guidance in real time. And in that way, the MS management really becomes seamlessly kind of integrated into Henry's everyday life, right? And it's not that MS is this, separate, awful diagnosis, that, is sort of this black cloud hanging over things. It's that, MS is a part of who Henry is, right? And it's something that he learns every day to to cope with, right? And to live with. And then it becomes that much less scary. And that's when he starts to develop that confidence where, hey, this isn't so bad or so daunting. I can do this, right? So by ensuring really everyone's voice is heard at every visit, Henry's able to thoughtfully consider all perspectives, at least from, either the two trusted adults, right? His mom and the provider in the visit, or, his 5 or 6 uncles that decided to come, as well to the visit to support him. Um, and it's in a supported setting, and he can kind of start to observe, but in an active listening way, and having him be involved in things like the scheduling appointments, and discussing side effects, and discussing, treatments, and, the things that really bother him about the treatments, right? And those are the things where, by seeing how adults, trusted adults, supportive adults in the room are also talking about these things, he then is able to gain that valuable perspective, and that helps sort of to translate into more mature, independent thinking, at an age where a lot of kids have trouble, during these developmental phases with foreseeing, potential consequences of, unhealthy lifestyles, right, and things like that. And so, it almost is, in a sense, like Henry has to grow up a little bit faster, right, than other kids his age. Um, and we don't want to obviously, put pressure on him, and make that sort of happen too quickly. But at the same time, the more we're able to sort of get him that confidence and those tools and skills to be more independent in general, the more then he can start to, be actively involved and take ownership of his MS, and, not let it, you know, not let it kind of burden him as much and, be such a a difficult hurdle to have to jump over. Um, and with all of that, sort of this shifts the conversation from the provider to the parent, really to the provider to the patient, right? And the key here is, even for young kids, the more that me as a provider, and the care team can have these one-on-one conversations, with the parent, of course, present, but be able to then, talk to the child and, and get their perspective. That's really the most important thing. Because then, then it becomes so much easier, to then have Henry be able to, manage his own care. Um, and kind of in a natural sense, a lot of times we find that then the adult caregiver, kind of can almost naturally sort of take a little bit of a step back, right? And not 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 be so sort of focused on, being the focal point of the conversation at every visit, and talking about, these are the things that I've noticed in Henry, but really what are the things that Henry himself is feeling, and and giving him the space and the support to be able to voice those things. And what we often find is that then the goals and the expectations of the parents, Henry, the multiple aunts and uncles in the room, after these sorts of conversations, continue, and all of the voices are being heard, there often is this pretty amazing and almost magical kind of alignment of a lot of the sort of goals, expectations, that seem to be so different at the beginning, they start to kind of coalesce. And so the third step really is the application, and the how do we then use all of these tools, skills, building blocks, that Henry has learned to, to really apply it in his everyday life, right? And so he starts to become more comfortable discussing MS, how it affects him. He starts to appreciate the importance, the value of taking over the management of his MS care. Um, it starts to become more of, something that, and I find that there's a lot of times when the transition process and conversations are done well, the child almost starts to become excited, about managing their MS care. It kind of empowers them to some degree, and that is such a mature, response at such an early age, and it's something that really I find, carries that patient, throughout their life, and really kind of helps them, to continue, regular follow-up visits, and, have their MRIs and have their labs, and, not lapse in treatment, and live healthy lifestyles, right? And so since he's been working from the beginning on sort of these gradual building blocks and integrating MS into his daily life, it suddenly doesn't become such a daunting task. And that's especially with that ongoing support from his care team, from all the resources at places like the National MS Society, as well as, his mom, and all of his family members, right? And so the idea in this step is not to, by any means, kind of withdraw, right, any of those support networks, but actually to even to bolster them, and help, and sort of encourage Henry's progress at this stage, and that kind of drive towards independence. And so step 4 is really kind of the focusing on, starting to identify barrier, more discrete, and having more open conversations about what barriers do we feel are are major ones for the particular, patient and family um, that's coming to see you. And like I said, a lot of those barriers already will kind of be teased out from all of these previous transition focused conversations. And I'll give you one example of that, which I think highlights this well. So if you think back, remember at the beginning, in step one, when discussing kind of the goals and expectations, Henry had said he wanted to be able to stay active and play sports, and was worried about how MS was going to affect his body and his physical capacity, right? And then his mom very differently wanted him, to be able to attend college, despite all of the MS, related treatments and side effects and things that mom was concerned about. And so if that remains true, and some of this is where, continuing to set aside those 5-10 minutes at every visit to discuss transition and check in on, are those goals and expectations being met? It may be that some of those expectations have evolved, right? And goals have evolved or changed, or there may be new ones, right? And each of those things needs to be, I think keeping sort of a log, right? Almost like a goals expectations log, I think can be really, really helpful. And, your provider, your care team can help with this, where, you have these goals expectations, and then at each visit, you sort of, you look at the list and you check off which ones you feel like are being met well and which ones maybe, you want to have some further discussion on, right? And then sort of the goals and expectations list almost starts to become a list of, okay, what are the ongoing challenges, in the everyday life of the child that might very well pose potential limitations or barriers on that effective transition, and Henry being able to then independently take over his MS care and his management. And so a couple of examples of that, um, if you just go back one slide for me. So some examples that might require some further discussion. So if Henry's wants to stay so active, right, and play soccer and, do well in school and all of those things, you can imagine that all of the scheduling, right, around that might get in the way of him being able to really keep up with his appointments, his infusions, and his blood work, right? And so that's a potential big barrier to, him being able to continue managing his care independently moving forward. And then from the mom's, standpoint, in terms of that discussion about wanting him to attend college, from stemming from that very sort of simple initial conversation, how then might him moving away to college impact his MS care? And that can include all kinds of things, right? In terms of travel and distance and ability to continue infusions and facility and, local, getting established with a local provider. And in addition to, sort of staying in touch with his, his peds MS provider, and all of those types of things. And then the last step really is that, that time is really nearing towards actual transition of care. And as that starts to kind of get closer, it's so important to revisit that discussion about, how transition is going to occur, who will take over care, if care is transferred to another team, how will everyone make sure that, that person is well informed about the case? Is there an opportunity to meet with, with the new team in conjunction, with your current team to sort of help to kind of ease that transition? who will be prescribing treatments. If it's an infusion, will they be given in the same place, a different place? Will the pre-medication, the protocols, the insurance authorization, the scheduling, will the labs, will it all be done in the same way? Will it be different? How will it be different? These are huge things for the family and the patient to be able to be aware of. Are there insurance issues that could arise once the child turns 18? Not Is there stipulations on, and laws and insurance coverage? All of those things change all the time, in terms of how long a child can be under their parents' coverage before they have to be, taken off of it. That also depends on if they're going to college and have a college insurance plan. What does the financial obligation look like for continuing medical visits and MRIs and infusions? Does a social worker need to be involved with a specific case to help in terms of potential financial resources? On the research side, are there any studies that the child's a part of that might be affected by transition, and how is that going to work? Um, and then one of the most important things is, if the patient or new provider, has questions, how can they then contact the prior care team? And, the emphasis here is that we all, as pediatric MS, specialists, we all want to make sure that this happens as smoothly and as best as it possibly can. And so, as long as we need to be part of that conversation and the transition process, that's what we need to do. And so being able to use that as a resource is, life is a lifelong, endeavor. And so just to kind of finish up, I think kind of reflecting a little bit on, thinking through some of these examples of, Henry and his mom, which ones might apply to you, which ones might not. Are there other things, that are important to bring up with your provider and your care team? And I want you to do a little bit of homework and really kind of discuss at the next visit with your care team. Just if you haven't brought these kinds of questions and conversations up, just ask the questions, and I think you'll be pleasantly surprised at how open and amenable your care team is to really trying to figure these out and work with you to identify barriers ahead of time, so that the transition process can be as smooth as possible. And it's really never the wrong time. It's never too late to bring these questions up. Wherever you might be in the process is absolutely okay. It doesn't have to be, again, in the same order that I presented here or the same time frame. I mean, whatever you and your provider and care team are most comfortable with, that is the best option. And really the bottom line is to start now, and and I think that the focusing on the transition process, and just bringing it to attention and having those conversations is the best possible way to prepare patients and families for transition.
Great. Thank you so much, Dr. Abrams. I really appreciated all the information you shared here and some really tangible next steps that families can take as they consider the transition process. So we appreciate your time and expertise. I do want to take a few moments to share some additional resources for families. Um, you've learned a lot about MS and a lot of ways you can feel your best, but a reminder that the Society is here for you through each new change you go through with your MS. The best way to find all of the resources available, including those listed here, is to visit our website. You can also view a comprehensive flyer of links to pediatric MS resources with our Pediatric MS Resource Guide, again, something that you can find on our website. And if there's ever a time when you have questions or need additional support, you can contact an MS Navigator. The Society's MS Navigators are very skilled, very kind professionals who are supportive people that can help you work through the challenges and changes with MS based on your personal experience. That might mean emotional support resources, access and referrals to MS healthcare specialists, accessible and affording housing possibilities, and much, much more. They really can help you figure out what you need and how to talk to the right people to get it. You can talk to an MS Navigator over email, by direct message on our website, or you can call 1-800 344 4867 to learn more. They can help both parents and kids and give you helpful resources for your whole family. If you are a kid and you want to talk to an MS Navigator, do be sure to make sure your parents know you're calling them first. Also, a reminder about connection opportunities. We would like for you to get connected with people, your peers, who are affected by pediatric MS similarly. Check out our MS Youngsters group for teens. That meets virtually on a monthly basis, and it's led by a society trained volunteer. You can also follow them on Instagram at MS Youngsters. Parents are also invited to join our group for parents of a child currently 25 or under who has an MS diagnosis. The group format rotates every other month between social connection focused discussion and also educational presentations. So again, head to our website to learn more about both of those opportunities. Thank you again for your time. We are so glad you joined us today and hope to see you again soon.